Hi.
Thank you very much for agreeing to speak with me tonight.
My pleasure.
Very nice. How are you doing, madam?
I'm very good, thank you.
Very nice. Let me know more about yourself, madam. Where are you from?
That's a very difficult question for me to answer because basically I'm a Tamilian, but I was born in Chennai, but grew up to a large extent in Bangalore only. And my father was in the army, so traveled around India. So did my schooling in various parts, both north, south, east, everywhere. And then I did my MBBS from Madras Medical College because that was his last posting. He was posted in Chennai, earlier Madras. And I did my final years of high school there and then did a year of intermediate or PUC in Ethiraj College.
Nice.
So that's in Chennai.
Yes.
And then I did my undergrad from Madras Medical College. And then journeys took me, I did my All India exam and did my MD from SCB Cuttack, that is Orissa.
Yes.
Then I went on to do my DM endocrine from All India Institute, Delhi, and then came here to practice endocrine.
Nice. All over the country.
All over. Schooling though was all over. Even my medical training, if you see, was all over. Yeah.
And what made you choose medicine though? How did you end up being a doctor?
Well, again, in those days when we got into medicine, I was just 16 years old. And it's very difficult to understand what it was. I would say it was possibly a little bit of, at that time, either you have to be a doctor or you have to be an engineer. Especially in South Indian families, there was no other profession. My mother, to a large extent, was responsible for me to get into medicine. But once I got in, then it was my choice, of course. And I was very passionate about the subject and seeing people get well. And those things were the ones which actually propelled me to continue medicine and basically medicine. That's why I did MD medicine and then did my DM endocrine.
Were there other doctors in the family who inspired you or?
Oh, well, my uncle, actually ours is basically an engineering family. Largely all my lineage, I can say, are all engineers. In fact, my grandfather, if you know Jayanagar, there is a Madhavan's Park. Madhavan is my grandfather.
Very nice.
Yeah, so he was the chief engineer here and who sort of built Jayanagar and planned Jayanagar. Jayanagar was the first part of planned Bangalore. And so my father is also an engineer. He was in the army, like I said, he was in the military engineering service. So only one of my relatives, my uncle, that is Chittappa, he is a doctor. He's an anesthetist in Chennai.
Nice.
Otherwise, my generation, yes, I have a few doctor cousins. But otherwise, I think in my family, basically engineers.
So you chose to be a doctor.
Yeah.
Oh. And then you chose general medicine, is it?
Yes.
As a specialization?
General medicine. That came spontaneously. There was no choice over there. When I did medicine itself, I wanted to do general medicine only. Though I was good in surgery, but I didn't like so much of trauma and all that. So I thought medicine, I'm best suited to do medicine, and that is why I chose MD medicine.
Was there any particular event or patient that you saw or some conditions that you saw which said, yes, I'm going to be a physician?
See, actually, when I trained in Chennai, the whole responsibility of patients used to be given to house surgeons, interns, at that point of time. So I was caring for a ward of something like 40 patients at the same time, drawing blood, doing their treatment, while our professors used to just come for rounds. And so the final moment of treatment was always with the intern, and sometimes we used to take our help from our residents, senior residents, or even postgraduate students. But right from drawing blood to prescription, everything we had to do. So we became part of our family. And the culture there was so much like you have to become part of. Life was a hospital. There was no other life.
True.
So but in the surgical field, there was always a person senior to us, like the main surgeon, who was doing. And I felt my skill set was not very good in surgery. When I used to make those suturing or something, my skill set was not that good. So I thought that medicine I'm better suited for.
Nice. So when did you finish your medicine, general medicine?
I finished my medicine in 84.
84. And then you chose endocrinology, is it?
No, I finished my that was MBBS. I finished in '84. I then had a break. I got married and had a kid. So then I did my medicine, MD medicine. I finished in '94. There was a large gap. Then immediately after that, I joined my DM endocrine. Yeah, when I did medicine, after finishing medicine, if you see that one field of science where there's a very rapid improvement in the patient's condition, if you're looking at hypothyroid, patient comes in so sick, he's all bloated out, and then you give him one small thyroxine tablet, he's fine. And if you look at any specialty in endocrine of adrenal crisis, they come sick, Sheehan syndrome, they come sick, but like a miracle they become fine. That feature sort of fascinated me. I said, my goodness, this is nothing, we're doing nothing, just giving a couple of medicines and patient is fine. Unlike any other specialty, if you see nephrology, so much morbidity, mortality, and they do, very few patients become fully fine after they go into chronic kidney disease. Or so I found this very fascinating. So the patient's response is so good and so quick. So, and sort of, it's a field very similar to mathematics. 1 and 1 is only 2, which is very rare in medicine. 1 and 1 can be 5, 7, 10, anything.
Yes.
But this is very much, a very simple science if you know the basis of it. So that is why I chose endocrine.
Okay. When you say endocrinology, what is it for lay people? What does endocrinology entail? Yeah,
so that is a very good question. Initially, people used to think it is either gastroenterology or endocrinology. So it took us a long time for people to understand there is a specialty called endocrine. So when you look at the glands, there are 2 types of glands. One is the exocrine glands and one is the endocrine glands. Exocrine glands are those which have ducts and throw their fluid into the ducts and then it works. While endocrine is a ductless system. So it throws its hormones, which is called hormones, vis-a-vis exocrine, which we call enzymes, and directly into the blood. So these are the endocrine glands. So basically the main gland is the pituitary gland, which is we call the master gland, and that regulates all the other endocrine glands in the body, which could include your thyroid, the pancreas, the adrenal, and so on and so forth. So each of these glands, like if you take pituitary, it has a controlling for all the systems, whether you're talking about thyroid or adrenal or reproductive function. So it's a controller. And then you have secondary problems of thyroid, adrenal, gonads, bones. So I think today it encompasses almost every organ in the body. And today I feel medicine is becoming more holistic. So there was definite cardiology, nephrology. Now it's becoming sort of metabolic with a lot of diabetes, becoming chronic metabolic care, which includes the cardiovascular problems as well as the nephrology. So it's becoming very sort of rounded or universal. So yeah, that is what is endocrine. I hope that was simple enough.
It is. Now, that's my next question, in fact. Now, you've been practicing for the last 30 years.
Right.
And would patients understand what endocrinology is, all these glands and things like that?
See, actually, it's important that they should. So as a teacher, if the student doesn't do well, it is not the problem of the student, it is the teacher. Same way, that is my belief, that if the patient does not realize what he has or what is endocrine, that is my failure. So for me, the crux of management largely is education. So education should be one of the main cornerstones of treatment. Giving drugs is one thing, but them understanding, because today we are dealing with chronic disorders. We are not dealing with acute diseases where the doctor writes a prescription and you're done. You take it for 5 days, you're fine. You're looking at diabetes, you're looking at dyslipidemia, you're looking at hypertension. These are chronic disorders. We cannot manage unless we get good cooperation from patient. So that is why education for patient is of prime importance, so that they cooperate with us with a good lifestyle. So many people ask me, they will ask, is this good for me? Like, let's say, is yoga good for me? There's less science or evidence to say yoga does good. But whatever it is, I say long term it is good for you. So finally, end of the day, everyone's goal is that we should live healthily.
Yeah.
Healthily. I think there's no other goal. If you really look down at everything is temporary and will pass, whether it's wealth or fame or whatever. But health will stay with you, and that's of prime importance.
True. Have you seen a shift in public education or awareness about endocrinology, about all these different systems you spoke about, adrenals, gonads and things like that, as an endocrine system? Are the public more educated these days? Are they aware?
See, there are certain topics they have become very aware of to a large extent because of social media, because of Google and all of these other platforms where the knowledge is available at your fingertips. But to large extent, some diseases they don't know or they don't realize, and they for them it is very troubling. Like, let's say a young girl of 3 years gets her periods.
3 years?
3 years, which we call precocious puberty. Or if a girl of 17 years just started her cycles or menarche around 13 years, and by 17 years she has entered menopause. So these are certain areas which are very troublesome. Knowledge is less. But if you look at common disorders like diabetes or thyroid, in fact even PCOS, that has become very common. And people today may come and tell me, I say, what is your problem? They'll say, I have PCOS. I said, what is that now? You tell me what problem, I'll tell you what disease you have. So yes, knowledge has improved. One, it is good, but two, it is also leading to a lot of myths which people think is true, and they start following those without actually any evidence to say that is good or bad.
Mostly misinformation on social media.
Absolutely.
Probably, isn't it?
Especially about diet and things like that. No? Yeah.
And what is the bulk of your practice? Like, what are the major cases that you see on a daily basis?
So daily, I suppose the bulk would definitely be diabetes, and followed by thyroid and reproductive endocrine. PCOS, polycystic ovarian syndrome, is a very common problem now among youngsters, adolescents, young adults, 20s, 30s. So these are the most common problems we see. We do see rarely growth-related disorders. It may be very short stature or tall stature, which we call gigantism or acromegaly. We see problems related to adrenal glands. If it's excess, we call it Cushing syndrome. And if it's less, we say Addison's or hypocortisolism. So these are some of the rarer. But bulk is diabetes, thyroid, and PCOS, and reproductive endocrine.
Well, we get to read on the social media, of course, they say India is becoming the diabetes capital and things like that. What exactly is the burden of diabetes in our country?
So actually the burden is something like almost 1 in 4 to 1 in 5 persons are diabetic. Roughly around 1.6 million diabetics are there, 123 and speculated to become 146 in the near future. Million diabetics are there in our country, and a similar number apparently is undiagnosed, or some are even called pre-diabetes. So the numbers are huge. So that is why we are all concerned about diabetes in our country.
In your practice, what kind of a shift have you seen? Like 95 you started practicing, now it's
Right.
30 years now. What kind of a shift have you seen in the incidence and prevalence?
See, the main shift, of course, the numbers have increased, there's no doubt about it. But what we are seeing more often is that we are getting, the age is becoming younger and younger. I see even 8-year-olds with type 2 diabetes. As you know, diabetes are 2 types, type 2 and type 1. And earlier 8 means type 1. There was no doubt that this would be a type 2. But today we are seeing type 2 diabetes in younger individuals, 8 years and above. We are seeing increasing heart problems happening at a younger age, around 30s, which was unheard of.
Heart problems as a complication of diabetes.
Yes, in 30-year-old, 35-year-olds. So this is something that we are very worried about. We know that as Indians or Asian Indians, we have something called an Asian phenotype. We were not as obese as the Caucasians as far as BMI was concerned. In fact, when I started around 30 years back, like you said, I was into research, and all our population of patients would have a BMI of 25. BMI is body mass index, which is weight divided by height for those who are watching, and the Caucasian BMI would be 30, 32 when we are publishing papers. But now we do see even 30, 32 in our population. But what I wanted to bring to your notice, we are supposed to be called a thin fat Indian. What does this mean is that our BMI is low, but our fat content is very high. Our visceral fat, which is actually a metabolic problem, is very high compared to a Caucasian. So that is what is the problem for us, that we are uniquely having this thin fat obesity, and we also have diabetes coming a decade earlier, but now I feel it's much more than a decade. In Caucasian countries, diabetes starts at 50. Earlier we used to start 40, but now I think 25 is happening, because now both the parents were diabetic, so the risk of the children getting diabetes is very high. So we are getting younger and younger, and the complications are also getting at an earlier stage because of that. So these are the uniqueness in our population, that we are prone for, actually we are more prone for kidney disease and heart disease as a genetic problems. Yeah.
And is it more common in the urban population, or do you see any difference?
No,
in
there,
rural
you know, again, 30 years back there was a huge difference between urban and rural divide, but now that is also narrowing. So now even the rural population, we are seeing increasing diabetes population, and urban of course is increasing, but yes, the divide is becoming narrower. Compared to earlier.
Why do you think that is?
It is basically lifestyle, you know. When we talk about lifestyle, we are looking at your dietary habits, your physical activity, and your stress levels. I think anyone could tell that this has changed. So there is lot of fast food. People are working, they just make a fix of a breakfast or a lunch. There's no proper meal timings, and people are working late into the night, and their day-night cycle is also of surmount importance, as you know, and that is also getting upset. So this is one of the reasons. Then physical activity. People used to walk. My father, I remember, he will walk everywhere. He will walk 10 kilometers every day. Today, maximum we walk is around the house, or very often nowadays I have this in the younger population. I do 1 hour exercise, madam, they will come and tell. But what do you do rest of the day? Rest of the day they are
resting only.
So they are doing work, but it's not a physical activity. Like even in the house earlier, every work was done. Now we have washing machines, we have dishwashers. So work has become more sedentary. There's very little physical activity happening. So that increases insulin resistance and proneness for metabolic disorders. Even if you look at cardiac problems, the basis of that is also insulin resistance only, you know. So that is why all these problems are more. So we talked about diet being a fast fix, junk food eating is much more, physical activity is very less, and stress. Right from school there is stress. Right from when they start going 4th standard to 5th standard, their bags are so heavy, and homework,
Tuitions.
peer pressure, tuitions. You know, so I was asking many girls who now are 100 kilos, very easily one 8th standard girl will be 100 kilos. So why don't you do exercise? Madam, where is the time? The mother will tell me. 4 o'clock she comes, then she goes for tuition, then one more tuition. She is training for IITs, or she is training for medicine. So their days are packed. Exercise has, the importance of exercise has come down. Even in schools also, they have just one PT practice or period for about 45 minutes once or twice a week. It's not on a daily basis. So there's not much physical activity happening. And stress is taking that, because peer pressure, they should do IIT well, or they should get into medicine or into any professional course, that still is there. Though, of course, now arenas have opened up, you can do fashion designing or whatever, but even there is a peer pressure. It's because populations are so high, you have to compete with that many more to get where you want.
Well, one more thing I've heard is, it's in the public knowledge, that the FDA or whoever the authority that draws up criteria to be defined as or diagnosed as a diabetic they are reducing the numbers, so we are getting more diabetics. How much of a truth is there to that claim?
So, as far as diagnosis of diabetes is concerned, I don't think FDA has anything to do with that. They're more with the drugs, you know. So, this is organizations like maybe the American Diabetic Association or NHS or things like that, where you have also NICE guidelines from UK.
That's right.
Or we have these guidelines. Basically, one of the reasons it came down was they associated at which level of blood glucose do you get complications. Why for now the diagnosis of diabetes, if you're doing a glucose tolerance test, the cutoff is 200 post 2 hours to say you're diabetic. The 200 is related to diabetic retinopathy. So they found that at that level, most people will have diabetic retinopathy. So that is where those criteria were held. And also earlier the fasting was 140. Now it has changed to 126 for the diagnosis of diabetes, the fasting. And that is also related to, for 200, what matches is 126. So I don't think that is a problem as far as diagnosis is concerned. And if you look at management also, today we know pre-diabetes, that is even you're not diabetic, but you're just having impaired glucose tolerance or dysglycemia, that itself is a risk. Your risk for both micro or macrovascular, micro means small vessels, macro is large vessels, are at risk. They are going to get endothelial dysfunction, which means the arteries are not functioning that well, to leading to that organ damage. So when it can happen in pre-diabetes, then our control also should be better than pre-diabetes, isn't it? But the reason why we are very worried about keeping the blood glucose very low is on the other side we have hypoglycemia or low glucose, which is even worse than high glucose. So yes, that is why those definitions of what is control has been that, okay, your complication rates will be less, but at the same time even hypoglycemic rates will be less.
So it's not just shifting goalposts for some other
I don't
ulterior
think
motives.
so. I don't think
That's a
so.
common myth which goes on.
Yes, I don't think so.
Any other common myths that you heard from patients which should not be followed?
Common myths, mainly like we discussed earlier, was diet. So many times people over social media will be saying this is good for you and that is not good for you. Like today, someone said they wanted to drink one commercial drink and they are not drinking it once, they are drinking 8 times in a day. So I won't name the brand, but that's promotion. And people think that there's a magic cure. But it is not their problem actually. Anyone who has a chronic disorder hopes magic will happen. So that is something which may happen. We're talking about remission of diabetes also nowadays. Magic may happen, but it's through hard work. It's not like a quick fix. Mainly this vegetables like bitter gourd is good for you, and those things we come across lots. We don't mind. If they say it's good for you, we say take, as long as it's not harmful. Sometimes people have a blind belief that Ayurvedic, homeopathic is very safe compared to allopathic medicines. That is not true. Ayurvedic and homeopathic do have their side effects. So I wouldn't say that branch of science is not good, but whatever it is should be well researched and then given to a patient. That is my point of view.
So just to complete the diet side of it, so who is the best person to contact if a diabetic has to get more advice or proper advice? Is it a dietitian or a diabetologist, endocrinologist? Who would advise them?
So I think a dietitian is good and an endocrinologist also is good, but basically it's not such rocket science that a patient cannot understand. Generally when we talk about diet, people say, oh doctor, today also I had a patient, doctor, these diets and all I cannot follow. So it's nothing very rigid. You know, if you say you have to stick to this, people won't stick. One thing is, it's a mindset. The minute you say don't do this, they will want to do it. So it's always a moderate diet. And basically the problem for us Indians is we are a carb-rich nation. We eat a lot of carbs and that is translating directly into glucose. So this is all I say. The concept of my plate, I try to encourage people to take, which is very simple. Half your plate is veggies, quarter plate carbs. You explain to them what is carbs, and then the quarter plate will be proteins. That is the difficulty for a South Indian diet or an Indian diet which is vegetarian to find a right source of protein. So you encourage them, say, okay, this is protein, add this, take more vegetables, because we don't take, when you ask someone, what's your breakfast? I would have told them 10 times before. They will say dosa. They will never say I had an omelette or I had some salad or something. They will only say dosa chutney. So that is so hard fixed in their mind that to change that and say, no, that is only quarter of your plate, rest 3/4 is not there, is a little difficult and a challenge. Yeah.
And how often do you see denial? Like
Always.
denial,
Always.
isn't it? They say, oh, this is the same diet what my father was eating, their father
Yes,
was eating,
yes.
that's what I'm eating.
Always. See, first, denial is in right from the start. I cannot be diabetic. I have no bad habits. I eat regularly. Their concept of regular and exercise. Then, after denial, then of course there is, depression, and then there is acceptance. And then till that stage, they need a lot of hand holding to tell them, okay, we are there for you. And at that stage, difficult to handle. So sometimes it is for fear. The denial is because of fear. It comes forth from a patient as if he is very, doesn't want to follow you, but actually inside is fear. So it doesn't mean that he doesn't want to see you. He's just scared. So this I've seen very often, that man may be very brusque in front of you, and then he needs counseling. As many times when a patient has not even met my eyes, I have found them at the end of my consultation to start crying. So, to say, yeah, I am scared, but I'm okay now. I know I can take care of myself. So, yeah, medicine is a journey,
isn't it?
with the patient. So it's little.
So how do you take care of these diabetics? Let's say a patient walked in, and what do they usually come with? Diabetic patients to you?
So most of them come with some complaints, maybe, with uncontrolled sugars, coming with maybe some infection, or just the symptoms of urination, or just knowing that their values are bad. Because, diabetes is a chronic disorder, and the most common symptom is having no symptom. So that is not a criteria we say. You should test, and if it is high, you should come. So they come with sometimes problems, sometimes they come with complications also. They've just diagnosed after an MI, or they've just diagnosed after they had some swelling and they had a kidney disease. That is rare. But yes, they do come even with complications. They never realize they're diabetic. But majority come with some acute symptoms. I had excess urination for the last 6 months. I'm losing weight, things like that. And I got my routine checked. My sugars were very high. So I came to consult. So basically anything they can come with. So it requires for them to understand diabetes. So that's the procedure we go through. So I talk to them a little bit. Then I send them to my educator dietitian. So he spends a good 45 minutes to an hour, because like I told you in the beginning, that education is very important. So he would go through a diet which they can follow. There's no point giving some diet and saying, okay, take this when the patient is not taking that kind of food. So we customize it to the patient, what they want, and we educate them. Education is again given in parts, as much as they can absorb for that day. Again, depends on patient. If patient is aware, we give them a little more education, but definitely how to monitor themselves, how to document that how they monitor themselves, what should be their goals. And once they are aware, they know. And then I give them a prescription, and I'd say, goal is to make my tablets less. Your goal is to make it so that you do the diet. I don't have anything in my hands except to give you medication, but you can do everything to reduce your medication by following a good lifestyle. So yes, to a large extent, my patient population do control, do give it their best effort, but there are certain seasons like the mango season, which I detest, then they all are so tempted. But otherwise, yes.
You'll see the entire demography.
Yes, changing, everything goes high at that time.